So good afternoon, everybody. So I must thank the NZOS to give me this opportunity to speak before you. So topic for today is the manual DSEC targeting ultra-thin flap. So those are the different two topics which I requested him. So to pick either one of these three. So this is a ultra-thin DSEC. So if we talk of the posterior lamellar procedures, these are DSEC and automated DSEC, DMEC and PDEC. So if you categorize DSEC into different categories, as a nano-thin, 50 to 49, ultra-thin DSEC, 50 to 99, thin DSEC is 100 to 150, and conventional is up till 250. DSEC procedure has certain advantages over the PKP, less invasive, smaller surgical incisions, no corneal graft suture, faster visual recovery, shorter post-operative care, PKP-induced astigmatism ranges 3 to 7 and almost none here in DSEC, lesser risk of sight-threatening complications, wound strength in lamellar graft superior, post-surgery strong eye less prone to injury, less risk of immune rejections of the transplanted cornea, non-penetrating surgery, less risk of intraocular complication like glaucoma, cataract, CME and RD. Post-operative discomfort and wound healing time is more for PKP. Certain disadvantages: steep learning curve, high endothelial cell loss rate in initial post-op period, graft dislocation, pupillary block, reports of graft dislocation in vitreous cavity in phakic, interface haze limiting 20/20 vision, more hyperopic shift compared to DMEC. DMEC is a procedure of choice nowadays, but it's a bit cumbersome. It has many advantages over the DSEC. Currently, the ability to perform DMEC is widely perceived as the hallmark of a superior technical powers in the field of a corneal surgery, thereby unduly driving many novice surgeons to solely perform DMEC. Beyond the analysis of empirical evidence from published data, surgical decision-making must be informed by the pragmatic and prudent determination of the right procedure for the right patient by the right surgeon. Ultimately, both DMEC and ultra-thin DSEC represent valuable tools in the surgical armamentarium of any corneal specialist. So endothelial keratoplasty has become the procedure of choice for treating corneal endothelial dysfunction. Many corneal surgeons worldwide employ thin manual DSEC procedure comparing to DMEC. Comparing with the DMEC, definitely the DMEC has a few edges over this, but the final visual acuity is comparable with that. Slower visual rehabilitation compared to DMEC. However, visual recovery is expedited with the use of thinner corneal graft. Interface problem, folds in the donor tissue disc from maladaptation to the recipient stroma, hyperopic shift, decentration of the donor disc, and excess donor corneal thickness. But when you do ultra-thin DSEC, graft are less likely to require rebubbling procedure as well. In conclusion, DMEC is better if the graft thickness is more than 130. DSEC graft less than 70 is as good as DMEC graft is. So there are few publications which state that DSEC ultra-thin is as good as the DMEC graft is. Motivated by this statement, so we attempted this ultra-thin and we have started up on to ultra-thin DSEC. So this is a video. So this is a cantholysis being done before surgery because the IPF was short and it's going to trouble you while do the surgery. Taking care. Many surgeons, they have a gutter, predetermined gutter. Definitely when you take the patient, you have a PACI with you. Accordingly, you can start with this, but I usually go as with the crescent has a 300 micron depth. I would monitor there, and the bubble in the anterior chamber would guide me the thickness. I don't prefer sharp dissectors because it's easy with a blunt dissector to go into the pre-descimate or a descimate area. So you can always plan even less than 50 micron thickness graft in ultra-thin DSEC. So once you are done with the dissection till the limbus, we need to be very careful when you have this kind of dissection that you are not doing it at different strata, it's in the same plane. So once you are done with this, ensure that you have reached till limbus, and the graft you can easily separate. Now coming back to the patient, just 2.4 or 3 millimeter incision. Air bubble, you mark the graft size, scoring of the endothelium, Descemet fold. Ensure that you have taken it whole in one piece, preferably. I usually wash the anterior chamber because of debris or the methyl cellulose we have put onto the margin for the sealing of the wound. Then you inject the graft. Definitely it's a bit cumbersome to handle these graft, ultra thin graft as compared to ordinary DSEC grafts, manual DSEC grafts. Being thinner, you can mark the site if you require, but usually we do not need it. Bubble, and these folds in the Descemet would tell you the thickness. You're under 100. I always prefer, whenever I have to do a DSEC, to be around 100. This is 80, day 1. Post-op. This is 77 after 2 months. A problem with the manual DSEC is the risk of graft perforation by attempting to dissect too thin lenticule or creating a thick graft due to a fear of perforation. Certain modified techniques addresses this problem and is recommended for surgeons either embarking on the learning curve or who wish to achieve more consistently thin graft while reducing perforation rates. So sutureless collineal procedures are there, like bioadhesive, photochemical keratodesmosomes, laser promotion across linkage between the collagen molecule to produce tight seal without thermal damage that would prevent the frequent rebubble. Thank you.
Thank you, Dr. Shakeen. It was a beautiful